Hi everyone, welcome to today's webinar, Behavioral Health Transformation and the Changing Landscape of Infant Mental Health in Arkansas. I'm really excited to have our two presenters here with us today, Teresa Kramer and Nicola Edge. And I will introduce them here in just a minute, but before I do, I wanted to go over a couple of housekeeping items. We encourage you to ask questions during the presentation, and there's a question feature which is on the right side of your screen. So just type those in and we'll have hopefully a good bit of time at the end to answer those. And if you'd like to earn a CU, just be sure to stick around to the very end. We'll have a code that's given to this webinar. We actually only have one CEU for today, not 1.5. Sorry about that typo. We are recording this webinar and we'll upload the presentation to our website. And if you are interested in trainings such as this, check out our Facebook page. We frequently post about upcoming webinars and trainings and that sort of stuff. Okay, so I want to just quickly introduce our two speakers so you get to know them a little bit better. Dr. Teresa Kramer is a professor and chief psychologist at the UAMS Psychiatric Research Institute and serves as the director of Arkansas Building Effective Services for Trauma, or ARBEST. Because of her well-known expertise and commitment to improving the state's approach to behavioral health services for children with trauma, Dr. Kramer has been called upon to help shape policy in key child-serving agencies. Her dedication and outstanding contributions on the behalf of children with trauma have changed thousands of lives and will have lasting impact on Arkansas's children for years to come. And our other presenters today, Dr. Nicola Edge, is an associate professor at the UAMS Department at UAMS in the Department of Family and Preventive Medicine and serves as our best evaluator. Her specific areas of focus include children and families impacted by maternal substance use, depression, and traumatic events such as abuse and neglect, and she has been widely published in these areas. In addition to her role in the ARBEST team, she also directs an early childhood mental health consultation program in Arkansas called Project Play, as well as a teacher training and coaching program called REACH. So without further ado, I'm going to turn it over, I believe, to Dr. Edge first to tell us about today's webinar.
Great. Thanks, Ted, for the warm introduction. Thanks, everybody, for being with us today. So you can see on your screen a few of the things that we're hoping to cover today, and we'll just dive right in. So I'll be sharing some information, some background information on infant and early childhood mental health, some Arkansas statistics as well, and then we'll look at some changes coming to our service system as a result of changes to Medicaid. And then I'm going to turn it over to Dr. Kramer, who's going to talk about the kinds of treatments that Medicaid will be paying for young children and provide info about those trainings and how we can help clinicians be ready for the changes that are coming to Medicaid policy. So let's start with a little bit of background. So, we often find that when we talk about the mental health of young children, and particularly mental health treatment, it's really confusing for people. People's minds instantly go to kind of our classic view of treatment. They imagine talk therapy, and it's difficult to integrate young children or even babies into that picture. And there's lots of myths about young children's mental health. One is that mental health is an adult thing. Kids don't really have mental health or mental health problems. There's also a lot of misunderstandings about the things that we know support or undermine children's mental health. For example, we know that trauma is one of the things that can lead to mental health problems, yet many people believe that very young children won't remember or won't be affected by traumatic events, or that if we don't talk about it, they'll forget. It's also related to the idea that young children are inherently resilient, that they have great bounce back. And while that's true, we know that when children experience traumatic events, it undermines their mental health. It can have significant impacts on their development, and it can have long-term consequences on emotions, on behaviors, on physical health, on brain development. People also have myths about what we can do about it, about the treatment side, that you can't tell what's wrong with young children because they can't describe their symptoms to you, or that you can't do therapy with them because they aren't developmentally ready. When in fact, we're going to be talking today about several evidence-based treatments for children under the age of 5, many of which are increasingly practiced right here in Arkansas. So if those are some of the myths, let's get to some of the facts, a little bit of background information that's going to be reviewed for most of you, I think. So as many of you know, kind of one of the most important key principles of young child mental health is that children's development happens in the context of their relationships. So it's very hard to improve a young child's mental health without enhancing the quality of their relationships with the important adults in their lives. So what we know is that a dependable relationship with a loving caregiver is the key ingredient to healthy emotional development. You know, children are hardwired to bond or form an attachment with one or more of their main caregivers, which gives them that sense of security that they need to feel confident and comfortable to go out and explore the world. And so the skills that we want to be building in caregivers to support kids' mental health are things like being responsive to infants' cues, being responsive to children when they speak or point or reach out, establishing predictable, safe, developmentally appropriate routines in the household. We want parents that are teaching and modeling good social and emotional skills themselves. So supporting children as they learn to identify their feelings, to manage their feelings, to solve problems. We want parents to be able to provide support when a child is stressed or challenged, and to provide opportunities for exploration and play. It's really through those kinds of activities that support a strong relationship with the caregiver that the infant develops, that they learn how to interact with others, that they develop their sense of competence and self-worth. And these early relationships really shape their worldview. It's through that lens that they're going to see the world around them, and it will impact their future relationships. So what we know is that when children don't have a strong emotional tie to a caregiver, when those kind of things are not present, or that relationship has been disrupted, or there's been abuse or neglect, then children are at increased risk for mental health concerns. We might see social skill problems, we might see emotional problems, we might see behavior problems, and we might see changes to their physiology and to their brain development. And these things are going to carry with them throughout their life in a way that places them at higher risk for later problems like delinquency, substance abuse, depression later in life. So the good news, though, is that we know more now about how to help when children are at risk of developing mental health concerns because of these kinds of disruptions in their family or traumatic experiences. So we know ways to assess for these concerns, and we know how to provide treatment to parents and children together in ways that are appropriate even for our youngest. So let's get a little interaction going, and let's talk about the prevalence of mental health concerns in young children. So we've got a little poll. And so our poll question is, according to the CDC, the Centers for Disease Control, what percentage of Arkansas children ages 2 to 8 have a diagnosed emotional, behavioral, or developmental disorder? So I invite you to make your best guess. What do you think is the number? What percentages of Arkansas children ages 2 to 8 have a diagnosed emotional, behavioral, or developmental disorder? Click your answer.
Well, we got almost 80% response, so we'll last call for folks to click a answer here. So Nikki, I shared those results. Hopefully you can see those.
Yes, I can see those. So we have a fairly even distribution across the different answer options. And unfortunately, a recent study from the CDC tells us that Arkansas and Kentucky are tied for the highest rate of diagnosed emotional, developmental, or behavioral concerns, and it's 22%. So 37% of you were right on the nose, and others of you were not too far off. Let's see. Chad, oh, there it goes. Thank you. Okay, so let's see. So besides Arkansas, sort of looking at more national data, we estimate that about 1 in every 5 to 10 children under the age of 5 are going to experience significant difficulties with behavior and emotion regulation. And as we talked about, if these goes unaddressed, when children reach adolescence or adulthood, they're at very high risk for some very costly problems for us as a society. Substance abuse, risky sexual behavior, criminality, that really drive up the costs in our social service system. So why are we seeing this? What are some of the reasons that we're seeing such high rates in Arkansas? Well, unfortunately, there's evidence that Arkansas families are highly stressed. Parents in Arkansas experience higher rates of mental health and substance abuse problems than you see in some other parts of the nation. We have a higher poverty rate. Many of our families are living in stress and poverty. And we have a record number of children coming into our foster system because of abuse or neglect, and most of them are very young. All these things are going to create a greater likelihood of mental health concerns for young kids. Again, as I keep saying, the good news, though, is that we know ways in which we can change the trajectory that children are on. Unfortunately, our current mental health treatment system hasn't really caught up to the science of early childhood mental health. So we know what to do, but we're not really well preparing our clinicians to come straight out of school and be prepared to serve our youngest children and their families with approaches that are proven effective. So we've done some surveying of our mental health treatment providers of children and adolescents in Arkansas, and basically what we see is that the younger the child, the less our clinicians feel able to assess the child for concerns or to provide evidence-based treatment for children and their caregivers. So we're going to talk about some ways, though, that that picture is starting to change around the nation, but especially here in Arkansas. So let's shift gears now and talk about what's happening at the state level to create the kind of conditions that are going to help our practice catch up with our science. It will not be a surprise to, I'm sure, anyone on the phone that the big thing happening right now is the transformation of our whole Medicaid-funded behavioral health system. So I'm not going to cover transformation as a whole. That's way too complicated a topic today, but we're going to talk about a few pieces that relate to the infant mental health picture. So what we have is basically Medicaid acknowledging for the first time that very young children and their families have unique needs, and they want to put some protections in place to ensure that our youngest children get developmentally appropriate services, and also to ensure that we don't waste this opportunity to intervene early when we have children at high risk of problems. You know, we hear this from time to time from parents who believe that treatment doesn't work because they've been in treatment. They've been in treatment for 2 years. Their child's been getting individual therapy for 2 years, and mental health services just must not work. And what we want to see is every family getting the kind of services that are most likely to be effective. So to ensure that that happens, Medicaid is putting new guidelines into place that providers of services to our youngest children need to be approved by DHS, by the Division of Adult Aging and Behavioral Health Services, essentially indicating that they're appropriately qualified to provide infant mental health services. So part of being qualified is going to be training in diagnosis and training in treatment models that have been shown to be effective. And we'll talk more about the specifics of those criteria in a minute. So let's talk a little bit more about some of the implications and some of the reasons. What Medicaid is basically recognizing is, as we've been talking about on the call so far, young children develop in the context of their relationships. So Medicaid is really requiring services that address parents and caregivers and children together. So individual therapy as a primary mode of treatment is not going to be available anymore. And we know that this is going to have some changes for our systems. This is going to have implications, for example, for how services are provided in some of our preschools or other early care and education settings. And, you know, we believe that clinically this makes a ton of sense. So what's really going to improve children's outcomes short-term and long-term is strengthening their relationships with their caregivers, ensuring safety in those relationships, and giving caregivers the skills that they need to support young children's development. Because what we know really is that the younger the child, the less capacity they would ever have to generalize skills that they might learn in a therapist's office to other settings like their preschool or home without consistent adult support. So that's really why it's so important to have that caregiver involvement. So what we also acknowledge, though, is that most of our clinicians are not trained in developmentally appropriate ways of working with young children. But Medicaid is now saying that services will only be reimbursed when it's provided by a specially trained clinician. And so we know that there may be some gaps in services until we get our workforce built up to the level that we need. It may take a little bit of time for clinicians without specialized training to kind of make that shift. So let's talk a little bit more about the approval process for clinicians interested in serving young children and their families. So a number of months ago, DHS convened a work group to provide input to them on an approval process for clinicians, as well as address other system issues affecting young children, kind of to help them with the answer of how would we know someone's appropriately trained to serve this specialty population, and to provide the kind of dyadic, evidence-based treatment services DHS is asking for. So our work group was comprised of leadership of several mental health agencies, public and private, as well as state and university partners. And I'm going to walk you through kind of some of the recommendations that were made, and what you're seeing here are the ones that DHS adopted. So here's just the first basic criteria of who you need to be to provide infant mental health services under Medicaid. That's consistent with much of the other Medicaid requirements. Let's talk a little bit about the training requirements. So what DHS has adopted is that training in a one-day training in the DC 0 to 5 will be the standard. Many of you recently probably completed a 2-day training that's even longer and richer than what's going to be the base requirement moving forward. And so what is this training about? It's training in the diagnostic classification of mental health and developmental disorders of infancy and early childhood. The goal is really to support clinicians in diagnosing mental health problems in the youngest children in ways that are developmentally appropriate, kind of recognizing that mental health and mental health concerns look different in a baby or young child than they do in an adolescent or adult, and we have to be able to understand that and tease that apart. There's also a crosswalk between this diagnostic system and codes that we would see in other classification systems that would be needed for billing. We're learning that states are tweaking that to suit their own purposes, and that may be part of what happens moving forward here in Arkansas. So training in the DC 0 to 5 rolled out here in Arkansas in December and January, and we had about 150 clinicians in the state trained. And the feedback was really, really positive. And the training did a great job of really covering in depth the topics you see here on the slide. So some key, background concepts of infant mental health, a really good discussion of the risks and benefits of diagnosing very young ones. And then kind of this multi-axial framework, which is really helpful to keep us focused on the whole child. What's going on in the child's relationships? What's going on with them physically and developmentally, and how is that connected to their emotions and behavior? What's going on in their environment, and reminding us that all those pieces of the picture are important for us to assess. The next set of the training requirements revolves around clinicians needing to have completed training in an evidence-based dyadic treatment appropriate for children birth to 47 months and their caregivers, or being an active participant in an approved training process in an ongoing way. So DHS is going to maintain a list of what are acceptable models of treatment, and that will be available for you to peruse. And if you're interested in a training and a treatment that's not on that list, they're asking that that be presented for prior approval. So, the thing that Medicaid is really emphasizing is that clinicians need to be trained in treatments that have been proven effective. Otherwise, there's little quality control, and we might have missed an opportunity to do something that we know would be effective for young children. So let's talk a little bit about what it means to be evidence-based. So I know that most of you probably have a general idea of what we mean when we use that term. But basically, we're simply really just talking about using research to help us know which methods are most effective in clinical practice. So an evidence-based intervention has been studied in ways that are scientifically sound, and it means that children's outcomes are improved compared to either treatment as usual or compared to other proven effective interventions. And so the two resources that you see listed there, the California Evidence-Based Clearinghouse and the NREP, are just searchable databases of these kinds of treatments. So for the purposes of Arkansas's infant mental health standards, what you see on your screen is how they're defining evidence-based services that Medicaid wants to be reimbursing. So if you look at these lists of evidence-based treatments, you'll see that there's different levels of evidence that a treatment is effective. So if it's a newer treatment and studies are just emerging, it might be labeled as promising. And as stronger, more sort of scientifically sound studies come out, then evidence of effectiveness gets upgraded. The rating goes up. And so what Medicaid is looking for are for people to be trained in evidence-based practices that are above the level of promising and moving into those higher ratings. So here's a list of trainings that our work group identified as meeting those criteria. These may not be the only ones, and the list may change over time, will change over time as new studies come out and evidence becomes stronger for newer approaches. The ones that you see with an asterisk beside them are ones where trainings are being supported in state, where we have capacity within our state to train on these approaches. And Dr. Kramer will be talking about those particular ones since they're the ones that are most easily accessible to most of us. So do we have clinicians on the webinar today that are trained in one of those treatments? If we do, can you type into the chat box which one you're trained in?
So while people are maybe typing that in, there just was just a quick question about somebody had asked if a registered play therapist is considered part of kind of this group as someone who's been trained. And I think I know what the answer is, but they'd probably need to check with the state's website to kind of the slide we're on now. Is that correct?
Right. Yeah, play therapy as such, the level of evidence isn't strong enough at this time to make this list. Really, also what we're considering there is that DHS is looking not just for stronger science, but also for, again, dyadic treatment, so that active caregiver involvement and the focus being on building the skills of the caregiver as opposed to focusing more on the child. And Dr. Kramer can probably address that more in her section better than I can.
Okay, and there's a number of clinicians typing in that, you know, TF-CBT, CPP, PCIT, so.
Right, great. Well, we've got a savvy audience on the webinar today then. So for those of you who were typing into that chat box then, if you haven't already, you're gonna want to figure out how you can apply, and this is how. So the process is to be able to bill Medicaid under these standards is that you'll fill out an application. The details are available at the web address that you see, but if you have trouble, you know, copying that, I just literally Googled DAA, BHS, and infant mental health, and it popped right up. So you'll submit an application packet. It will go to DAA, BHS for review. Once approved, there'll be a renewal process every 2 years that'll involve some continuing education. And then I also wanted to note that DHS will make the determination whether there are some applicants that have met these criteria in an alternate way, like, you know, there are a few doctoral programs around the country where you would, as part of your graduate or postgraduate work, have been exposed to and been trained in one of these treatment models and in diagnosis. And so if that is, there's not many of those, but if that's been the case, then DHS will determine whether you meet the criteria that way. And I will just share a couple other tidbits that I think probably most of you know, but just in case, a few other random facts about behavioral health transformation and how it affects the youngest children. So just a reminder that children in this age group are eligible for Tier 1 services only. The list of services that you see are the ones that are going to be available for this age group. And there's been conversation about this. We realize that there's been lots of questions about special populations of very young children that could realistically need more intense or longer services than are typically offered in Tier 1, you know, young foster children, for example. And DHS has acknowledged that's something that they're looking at. They'll continue to monitor that as we move forward with transformation. And then if changes need to be made in the future, they're sort of keeping their eye on that. One last poll before we turn it over to Dr. Kramer. So now that we've talked about what kind of treatment services will be paid for by Medicaid, I've mentioned before, many of us haven't really been exposed to what treatment looks like on a practical level when it comes to services for young children. So let's review and test our knowledge with a little poll. So which approach best describes most evidence-based mental health treatments for very young children? The therapist teaches the child new skills, the therapist and child explore feelings through play, or the therapist and parent work together to support the child? Click your vote.
Okay, last call for answers. We got most folks responded. So last call. I'm going to go ahead and close it.
Well, absolutely. Most of you have the correct answer. 89% therapist and parent work together to support the child. So this is Dr. Kramer. Nikki and I have switched seats now, and I'm going to be taking on the next part, which is really focusing on those evidence-based treatments. So as Dr. Edge mentioned, the focus is going to be on dyadic treatment. And as she talked about, young children develop within the context of relationships. So that means that the parent and or the caregiver and the child will be in the therapy together. That doesn't necessarily mean that they're in there, 60 minutes out of the 60-minute session, but it does mean that they are involved together for the majority of the time, and the therapist really is working with both of them to help build that relationship. The dyadic treatment recognizes that children develop in the context of relationships, and that these relationships are really important for them to regulate their physiological responses, to help regulate their emotional responses, to form internal working models of what relationships should look like, to provide a secure base for exploration and learning. So basically getting that foundation of attachment so that a child feels comfortable in kind of going out and exploring the world and then coming back to the secure base and then going back out again into the exploration. It's the model that really develops behaviors and social skills for the child. So it's such an important part of a child's development that, lo and behold, it's not surprising that it also should be the context for the treatment. So when we look at some of the interventions that are available, and these are the ones in particular that are, we provide training through ARBEST, which is one of the reasons why Dr. Edge and I are so very interested in this, because not only are these treatments dyadic treatments that are evidence-based, but they also are very effective when there is a child who's been exposed to trauma. So if we look at the continuum, 0 to 18 years of age, the TF-CBT actually covers the time period from 3 years of age to 18 years of age. And if any of you listened to Dr. Manarino's webinar, I think it was a couple of weeks ago, on working with really young children, you might remember that TF-CBT was actually developed based on kids who were like at the lower end of the age spectrum, so about 3 to 5 years old. So TF-CBT can be used all the way up through adolescence, but it is an extremely effective intervention, particularly those children who've experienced trauma for that younger age group. Then if we look at parent-child interaction therapy, or PCIT, the age range for which that is most effective is about 2 years of age to about 7 years of age. And I'm going to be talking about PCIT just a little in more detail in just a minute. And then we have the child-parent psychotherapy, and that is for birth to about age 5. So you've got this wonderful continuum of birth all the way up through 18 years of age. And we really are covering those the infant and early childhood age groups through these treatments. So I want to say just a little bit about the importance of fidelity with these models. So it's not only like really good to go get the training, it's also important that you actually do the treatment once you get the training. And we know that therapists tend to drift. So in other words, they go to the training, they're very excited, they're very passionate about the new model, and then over time begin to drift. And the problem with that is that the treatments have been shown to be effective when the components are implemented in a very consistent way. So we not only train therapists, but we also do the consultation calls so that you can get some assistance on how to actually implement this in the real world and get some practice with people who can give you some guidance and who can support you on how to do this. The treatment duration is dependent on skill acquisition and competency. So if the therapist skips around, doesn't follow kind of what the treatment guidelines are and the structure of the treatment, the progress can actually be negatively affected. So sometimes we hear that therapists are, I kind of go in and I do this piece, and then I take this piece of PCIT and this other piece of CPP, and that really doesn't hold the model to what it was originally intended to do. So I just want to make sure that when you get your training, you really do practice that model, rehearse it, make sure that you learn it well, and learn those components. The treatment developers have spent years understanding and testing the interventions, and with particular emphasis on each of the specific components. So if you're someone who's going to assume that you can pull out what the most effective components are, so you can create your own eclectic intervention, it may not end up being as effective. These treatment developers, as I said, have spent years of time, energy, resources determining which one of these factors actually work best for that particular treatment model. And then finally, mixing treatments can also be confusing to the child and the parent. So we really recommend that you stay true to the model, but be creative within the treatment parameters. So, as Dr. Manarino always says, if you're not having fun while you're doing the TF-CBT, then you're not doing it right. So you can certainly be very creative and figure out really innovative ways of implementing the treatment and still stay true to the actual model. So with that in mind, just a note for directors and supervisors, I'm going to talk about each of the individual models, not as much emphasis on TF-CBT because we've rolled that out and that's been going on now, I think, for 8-9 years. So each EBT model varies in their training requirements. So we have differences in the number of in-person training sessions, what kind of consultation call commitment there is, whether it's 6 months all the way up to 18 months, the number of cases that are needed to complete training, what's required in terms of infrastructure, renovation, or building, and then also therapy supplies. So just for any supervisors or directors who are on the phone, don't assume that when your therapist says, I'm going to go do PCIT, that that's something that they can go off and do independently and then come back and just start practicing. It really does require a commitment on the part of the agency and also the supervisor and or director so that the therapist can implement that model most effectively. So for trauma-focused cognitive behavioral therapy, and I noticed there were quite a few of you, as I said, this is for children who are ages 3 to 18 who have a known trauma history, and that can include an acute trauma, multiple traumas, or complex trauma. And usually the child has fairly prominent trauma symptoms such as PTSD, with or without a combination of depression, anxiety, and there may be some behavioral problems as well. TF-CBT is appropriate for children who are within their own home, but it can also be children who are in foster care. We've also recently seen some success in implementing this in residential treatment facilities, particularly if the child has kind of a lengthy duration of stay, because then that way they can actually get the TF-CBT and probably the entire dose of treatment while they are there. And it can be completed in a variety of of settings. We do not recommend, however, that it be started in a hospital setting because usually the child is discharged before the trauma treatment actually begins. What we can recommend is that the prac skills are started. Again, we don't usually have a lot of very young children, 0 to 4, who are hospitalized, but for other children in other age groups. And the TF-CBT treatment structure is about 8 to 25 sessions, and each session is about an hour to an hour and a half weekly. It's divided into individual child and parent sessions, although with really young children, more likely you're going to have the parent in the room for the majority of the session rather than you just working individually with the child. There's going to be a lot of teaching of the child and then teaching of the parent so that the parent can reinforce some of the behaviors, particularly the prac skills like the relaxation at home. There will be similar topics that'll be covered in the parent and child sessions. And as I said, combined parent-child time in most of the sessions. And just to kind of refresh people's memory, the TF-CBT components, which are applicable no matter what age group, is that you're going to have psychoeducation and parenting skills, relaxation, affect modulation, and cognitive coping, which are what we call the prac skills. The one that probably is going to show some variation for the child who's 3 years old and up, or it's going to be more to the cognitive coping, depending upon their ability to understand thoughts and the differences between thoughts and feelings. But most 3-year-olds are really capable on a concrete level of getting that, and they maybe not analyzing things on a more meaningful level, but they do understand kind of the basic differences between thoughts and feelings. And then the trauma narrative and processing can be included. Again, that's usually not as complicated as what you might find with an adolescent. The in vivo mastery of trauma reminders, and then, of course, the conjoint child-parent sessions. The enhancing future safety and development, a lot of times, we put that a lot more on the responsibility of the parent or the caregiver for the younger children, rather than compared to adolescents. And for those of you who are really interested in knowing a little bit more about practicing TF-CBT with that young age group, I invite you to view the webinar that Dr. Manarino did several weeks ago. And this is the link to that. As I said, our rollout of TF-CBT, for those of you who don't know, it's a 2-day, well, first you go online and you complete TF-CBT training at the Medical University of South Carolina, and then you are eligible to come to the 2-day face-to-face training with our international trainers, Dr. Ben Siegel and Dr. Jan Church. And then after that, you will do a consultation call, and that consultation call usually lasts about 6 months, and it's an hour every other week. So it's really important that you are seeing kids when you start this process, because you will be presenting cases on the calls, and you are required to present 2 cases during that 6-month period. So if you do not see children, you're not going to be able to get that certification. So we just want to make sure that people understand that. And that's, there is, with regard to the TF-CBT for little kids and getting that certification to be a mental health provider for younger children, there's no requirement that you have to present on 0 to 5, 3 to 5-year-old kids. It's just that you finished that. But we do recommend the webinar, and we will also be doing some continuing education around using TF-CBT with younger children. The parent-child interaction therapy is one that ARBEST has just recently initiated, and that is for children ages 2 through 7. And the parent or caregiver must attend, and they must have in-person contact with the child at least 3 days per week. These children usually have behavioral problems. There may be some type of abuse that's occurred within the home. We do allow parents that have had some issues around abuse to be part of the PCIT, but we do not allow sexual abuse perpetrators to be part of PCIT. And as I said, that is the parent and child together. The model for that is it is done with a real-time coaching. In other words, the parent caregiver has a bug in the ear and the therapist is behind a one-way mirror and more or less coaches the parent about how to engage in the positive parenting behaviors that we really want to see developed. There are two phases. The first one is child-directed interaction, which we also call relationship enhancement. And then the second phase is parent-directed interaction, or the discipline phase. And many times parents will come in and they really want to get to that discipline piece. Okay, it's time, this kid's got behavioral problems, we really need to get going. And what we're really trying to do is work on the positive aspects of the parent before they get into the session, before they get into that discipline phase. So we go with the relationship piece. This is mastery-based, so there's no time limit. So you graduate based upon the skills the parent has developed over time. And I'm just going to say a little bit about some of the components. The first one is praise, where the parent actually learns how to say really positive things about what the child is doing. Like, oh, you're doing such a good job of putting away your toys, or I really like the way that you're playing quietly while I watch. So making sure that you're doing that positive reinforcement for the child. The reflect piece of the pride skill is the child might say something like, look, I drew a picture of a person, and the parent will say, yes, you made a picture of a person. So it's not really, you're basically just kind of reflecting what they did or what they're saying back to them. The third one is imitate. So the child might draw pictures of circles on the paper, and the parent will say, look, I'm drawing circles too. So it's a way for both of them to enjoy an activity together simultaneously, and for the parent just to be kind of doing the same thing that the child is doing while they're doing it. The third one is describing. So the parent might say, the child might say something like, look, I'm making a tower, and the parent will say, yes, you're making a tall tower with all yellow blocks. So it's basically just the parent showing the child that he or she is paying attention to them. And then the final one is enjoy. So the parent might say something like, you are being so gentle with these toys, and I really enjoy working with you when you're being so careful. So it's really just enjoying time and reflecting that back to the child. The next phase, the discipline phase, really has two basic skills that the parent will develop. One is called effective commands, and the other is consistent discipline. So the effective demands are really learning how to ask the child to do things in an assertive way, not asking them questions like, would you please put the chair back, but put the chair back now, please. And then also implementing discipline, primarily in the form of timeout, that will then reinforce when the child doesn't do what he or she is supposed to do, helps them to increase the likelihood that those behaviors will be engaged in. Parents sometimes need some help in implementing timeout. There's a lot of different ways that people talk about doing timeout, but the coaches or therapists in the PCIT actually do spend a lot of time helping the parent learn the most effective way of doing timeout. And if it's done the same way every time the child disobeys, it will be effective. Parents sometimes need to be sold on timeout. They will say, well, I've tried timeout, or yeah, I know, I've heard of that before, but it doesn't work. So a lot of times that has to be a big focus of the disciplinary stage, is just getting them to be compliant. I do want to say a couple of things about the requirements for successful training. Again, as we're moving into this need to have more evidence-based treatments, based on the Medicaid requirements, people are like, yeah, let me get that treatment. But it's really important that everybody understands that there are some requirements for agency readiness, as well as for the therapist readiness. So the agency readiness, they have to be able to allow therapists time away from clinical duties for all of the in-person training that I have listed here, as well as the consultation calls and the case presentations. They also need to make sure they assist therapists in receiving a sufficient number of referrals for that age group in the time frame. We have therapists who are going through PCIT, and their agencies are supporting them to go through that training, but they're not getting any referrals for kids, and you have to have cases in order to be able to progress to the next stage of the training. So you have to maintain a caseload of 2 to 4 cases so that you can eventually complete the required 2 full cases. And then finally, the agency needs to promote understanding among staff and leadership of the potentially unusual needs and requirements of successful PCIT cases. Like, some of these sessions might get pretty noisy when you're trying to work with the caregiver around timeout. There's also some infrastructure readiness that's required. There's a considerable amount of room needs and equipment for PCIT, and I've just kind of listed some of these, including the observation room and a timeout backup area. That does not have to be a separate room. Some people have done like just a separate area in a large room where there can actually be kind of a gate that the child is unable to enter or exit when they're in timeout. Maintaining an audio system which enables the therapist to hear the parent and the child, and then the therapist can actually speak to the parent without the child hearing through those earbuds. You need a video camera because there will be some sessions that will be recorded so that the UAMS trainers can actually review those for fidelity. And then some instruments that are needed to actually assess the clinical progress. And there's also appropriate PCIT toys. We've had agencies that just go by just about anything they can find at Toys R Us, and those are not necessarily the most appropriate or effective toys to use. So we do maintain a list if anybody's interested in that. For the therapist, again, master's degree or higher in mental health field, independently licensed, and again, they do have children on their caseload that are in the age range. We would hope they have experience in evidence-based treatments, but that's not necessarily something that has to happen. We do try to suggest that they're not currently in training for another evidence-based treatment because it can get really confusing. Again, you don't want to mix the models, and so it's better to just learn one and do that one really well at one time, and then later on you can take on other models. And then finally, and this was kind of a new one, that the trainee consents to information pertaining to their progress to be shared with their supervisor or agency. And this is primarily because the agency is devoting considerable resources to that therapist learning that particular model, and we really want to encourage the supervisor to be supportive of the trainee and to help them as best as possible so that that trainee can learn the model fully and be able to practice it enough so that they become very sufficient, very competent in it. So the next one is child-parent psychotherapy, and again, as I mentioned, that's appropriate for children ages 0 to 5, and it really focuses on those who've experienced traumatic stress, who have some type of behavioral attachment or any other kind of mental health problem. The rule is you really need to have consistent caregiver involvement, and that can be a foster parent or a biological parent, or even sometimes a grandparent if there's a kin fostership that's going on. If the plan is reunification and the biological parent appears to be engaged, safe, and relatively supportive, CPP can start with that person at any time. And sometimes you'll have some switching off, which is also, it's very helpful to have your CPP coach helping you through that, because there are some as you might imagine, some challenges to having one caregiver in and then bringing another one in somewhere along the line. With the CPP, the goals are to help the parent and child to be more accurate in understanding each other and helping with more of that attachment piece so that the parent is really emotionally, psychologically responsive to the child and learns how to do that, and can not only kind of respond when they are becoming emotionally aroused or physiologically aroused, but just respond to them on a very kind of one-to-one interaction where the child says something and the parent is actually able to respond back. We are working towards achieving reciprocity in the intimate relationship and responding realistically to threats where we believe that perhaps the child may not be safe. And again, especially when you have trauma, that's a child that's come from a traumatic background, it's really important to continue to assess that safety and how well that parent is responding to the needs of the child. It also works to put traumatic experience in perspective. Just like with the TF-CBT, the CPP, actually, we do not dodge the bullet. When the treatment begins, the child really understands that this treatment is for them to begin to explore what's happened to them. We use the words that the parent is used and or the child is used. We don't try to buffer that. We start with that very early exposure and we tell the child, this is a place for you to begin to talk about what's happened or to be able to show us what's happened through your play and for us to be able to respond to you and help you get better and not have as many nightmares or as many fears or concerns. We want to encourage normal development and, as I said, normalize the trauma response. So the central principles, it's reflective, it's primarily non-directive. The parent has the rightful place to serve as the child's guide through life and through this trauma. And it's our therapist's job to facilitate that parent's role and really help them become more confident in assuming that role. So it's not our role, which is really kind of the difference between the CPP and play therapy. It is not the therapist's role to help that child make meaning of the trauma. It is in the CPP world. It is really the mom or the dad's role, and that's what the therapist is kind of coaching them so that they learn how to do that and they can respond to the child's emotions. We use play. We encourage physical contact between the caregiver and the child and language that's appropriate for the child's developmental level. We model protective behavior. So, for example, if a child is doing something really unsafe in the room and the parent is not responding, the therapist is encouraged to respond to that child to keep him or her safe. I've had child that stands on a chair in the middle of the session and the parent is not responding, and so you need to intervene, but what you're basically doing is you are modeling for the parent how to do that in a protective and appropriate way. You're providing emotional support and empathic communication not only to the child but also to the caregiver. Many of these caregivers also have experienced extreme trauma, and they may be avoidant and have difficulty attending to their own emotional responsiveness. So the therapist is actually attending to that as well as what's going on with the child. They may also provide concrete assistance, case management, and crisis intervention. So the phases, you kind of have an assessment phase where there is a very thorough assessment of the child's traumas as well as what's happening with the parent and their symptoms. And then once you get finished with that phase, there's a feedback session with the caregiver where you kind of go through not only the child's traumas that have been reported and their symptoms, but also the caregiver, their trauma and their symptoms. So you really kind of synthesize it, put it all together, and then you talk about what your recommendations are for treatment thereafter. Then you actually have the core intervention, which is the treatment phase, and then you have the recapitulation and termination, which is basically kind of that winding down phase. Kind of you'll see some of the themes still emerging that came out of that core intervention, but you're basically working towards the final termination. The requirements for CPP for the agency, again, they need to be sure that they're allowing the therapist time away from their clinical duties. This is an 18-month training process, and it's pretty intensive because you have 3 different segments of training. You have a 3-day initial workshop, a 2-day follow-up at 6 months, and a 2-day follow-up at 12 months. Then you also have the therapist consultation calls, and what we really try to make sure is that there is a supervisor in each agency who's doing calls as well, so that we're really building that sustainability model. The preparation time, there's sometimes time needed to prepare your cases, to review cases before the call, so you need to make sure that that's included too. And assisting therapists and supervisors, and again, receiving a sufficient number of referrals, because if they don't get the 4 cases that are required for a therapist and 2 cases for a supervisor, they are not going to be able to get that final certification. There's also infrastructure readiness, again, having a room that's devoted to CPP, having an observation room. If you've got video, you could use that. There is not as much observation done in CPP as there is in PCIT. So you could do some video substitution for that piece of it. Most of the observation goes on during the assessment phase in CPP. There are treatment manuals to purchase, and then maintaining a supply of appropriate CPP toys. And there are toys for the assessment piece, and then there are toys for the actual treatment phase. There's also a therapist readiness for successful training in CPP. Again, master's degree, independently licensed, that they are actively treating children in those age groups. So how do I access training? The DC 0 to 5, the 2-day trainings have been completed. We anticipate that the 1-day trainings will be scheduled later in 2018. For the different 3 different treatment models that I've talked about already, TF-CBT, CPP, and PCIT, you can go to the ARBEST website and you can find that. We also send out regular emails, and you can also check on our Facebook page because we will announce the next training. We have one scheduled CPP in June, and the application will open up next week. And then we have the PCIT in July, and that application process will open up in mid-May. Questions?
Hey, thank you. We've had a number of questions, so we'll probably have to tackle those. A lot of them offline. They're
yeah, we can
specific
do that. Sure.
questions about. But one question, I'm going to just in interest of time just forward it to the CEU slide. But one question was around the process of applying for the infant mental health standard or certification. If a person is currently, while they're still, can they apply for it if they're still under the RSPMI, or do they have to?
Yeah, the RSPMI is not really relevant to this. This is actually the individual therapist who is applying, and they can go online. I think, did we have the web? Did we have this? Okay, we had the link up there. Okay, so you can go online and you can apply. It does not have anything to do with the RSPMI.
Okay. And just for folks who are interested in the CEU, if you watched as a group, just let me know who you watched with so I can check the attendance list. That helps me, and our code is displayed there up on the screen. Another question is with CPP and PCIT, there's some concern that the number of sessions might exceed what Tier 1 would allow. Either of you have any idea of what's the approval process to continue with CPP or PCIT?
We have already discussed that with DHS, and they understand that there are going to be some of these treatments like the CPP that might be longer than that Tier 1 basically allows. So what the therapist would do is they would make that initial request, and then they would ask for additional sessions and justify it, saying, I'm providing this evidence-based treatment, and here's the progress thus far.
Okay. And maybe the last question we'll be able to kind of tackle this afternoon is, before folks have to leave, but and this is, several people have asked the same version of the question, do you have to be certified by July 1, 2018 to keep working with children between the ages 3 to 5, or can you be in the process? I think a lot of folks are kind of worried that they missed the DC 0 to 5 training, and so there's been questions about the next one. So.
Yeah, and I know that you can be in the process of training for the evidence-based treatment. I don't know for sure about the DC 0 to 5. Yeah. My guess is that since they haven't rolled those out, it's going to be really hard for them to just, lay down the law and say July 1. So I would go ahead and apply and just see what happens. But, you can work with children, you just couldn't bill Medicaid. Now, I want to make sure that anybody can work with these kids. These are Medicaid requirements, that you cannot bill Medicaid if you're working with that age group and you haven't been through the training.
The other thing that I'll say is that DC 0 to 5, but anybody can bring a 0 to 3 trainer in for DC 0 to 5 training. That website is where you go to explore that. There are also regional and national trainings that can be attended. So I think that it was wonderful that the state was able to invest some resources, but some of our mental health programs may have to, also invest in getting clinicians to training or in bringing a trainer in.
Well, Dr. Kramer and Dr. Edge, thank you so much for today's webinar. Several folks have asked, will we have these slides available? I plan to kind of put an email out afterwards with this as a PDF, and I know there's lots of great resources for folks to check out, and we will tackle the questions you all had typed in but just didn't get a chance to answer right now. So I'll leave the slide up here for folks to email me, and hope everyone has a great rest of the week.
Okay, thank you so much, everyone.